So I had a couple of questions from Matteo in the first paper. So I was struck when if I got this right, you said that childhood conditions are some causal relationship to later life dementia, but childhood health doesn't, or the effect of childhood health is completely associated with education. And I was intrigued by that because the implication is that the conditions which affect dementia have no effect upon child health at the time. And that kind of links to my second question, which is that both of your independent variables here, childhood conditions and education, are completed a long time before we see the effect on later life dementia. So the question which arises is what is it that links cause and effect in this? Is this some kind of direct but long dormant effect, or are there some intervening variables that explain the outcome?
So I'm going to try and answer your first question. I'm actually very skeptical. The reason I just didn't present it for now, I'm going back because it is a working paper, that childhood health doesn't affect dementia-free life expectancy, And the reason I'm skeptical is because I actually found an effect for dementia incidence, so I'm not sure what actually is going on there. I don't know if childhood health is working primarily through education or some other sort of issue with the model itself. So I'm going to go back to that, and I wouldn't say that it doesn't have an effect on child health. And then as far as the direct and indirect pathways, I haven't studied that directly. That's actually a whole in this paper. I have a couple other ones that are kind of looking at it more closely in my dissertation. And what we're finding, at least with child conditions, is that a large part of the effect does go away. Education remains strong. It does get reduced. So it is working through health behaviors. It is working through occupational opportunity and a host of other sort of conditions. I don't know if that answered your question.
I'm going to use the chair prerogative here and ask a question of Valeria. Did you include age of grandchild in your models? Because I'm a little worried that younger children won't have homework, but in fact, even the staying overnight, grandparents may be reading to them and doing, if they're anything like me, I did lots of number tests with my children. That's what I do.
You're right, age of grandchildren is always a central variable. We haven't included, and I honestly don't recall how it is asked in ELSA, but I think the problem is always that that we never know exactly the age of the grandchild to whom the grandparents look after. So we might have, like in Share, the age of the youngest, or in Dea's data we have the age of a random child chosen to have more characteristics. In ELSA, I don't recall, I don't know if Bruno knows what it is. But yeah, but anyway, the problem is that we are not sure about what's the age of the grandchild to which they refer when they tell us what exactly they are doing. We know from previous literature that usually grandchildren in need of care are relatively young, so the older they get, the less likely it is that they are looked after. But of course, you're perfectly right, it might be this staying overnight, something of a 14 years old or an older one on average as compared to the younger ones.
Yeah, it wouldn't be uncommon in the UK for a grandparent to be there to receive a child who's at school to come home, and therefore would sit with them and do homework, and that, you know, technically that should be until they're 13 or something.
You're absolutely right. I mean, within this grandparenting in Europe network, we are really trying from different sources to get as much information as possible. We are very happy to have at least this information I've presented today, which so far was not available. But unfortunately, there's still much to know in this kind of research. But thank you.
Other questions? Yes?
I have a question for Sonia or for Daniela, the co-author. So, I'm just thinking that when you actually did mention this in your last slide, the healthcare utilization, right? So it probably is about screening or preventive kind of action, because you might want the healthcare use, the thing that is unlikely, like as possible, that is unlikely to be affected by your health, because this overestimated or underestimated of your health condition might be, as you said, so it might be due to your pre-health condition as well, right? So things like, I don't know, because you're working with older population, if you work with younger children, you might think of things like vaccination, for example, because it's unlikely to be affected by your pre-health condition. So things like maybe taking up a flu vaccine, or screening, like say you have certain age and you know the recommendation that maybe women of certain age you should go to screen for breast cancer, that kind of stuff as a criteria, whether you do that or not, instead of just using the number of visiting the doctors and so on.
Yeah, we would love to do that. Like, we would love to have information about screening more explicitly, if that's what I understood from your comment. But it's not covered well in the data, unfortunately. What we have done is we've split our sample into the very sick and the not very sick, and we still found the same effects. Thank you.
Further question?
I also have a question for Sonia, and I'll try to put it in two ways. One is you can read your results in a totally different way, which is that overconfident people save the largely public health system money. And that, we should compensate these overconfident men for not bothering the health system so much. And the serious way to put it is that often when people make the case for mental health interventions, they point to research that people who've had mental health interventions and hence had a reduced mental health problem are less likely to show up for GPs and hospital visits and hence save the NHS money. So in that case, that is indeed seen as a worthwhile investment. Whereas in your case, you say, oh, this is lack of prevention, this is something bad, which is really the same in health saving. So to a certain extent, there's an inconsistency there. Either this is truly a health saving, in which case, maybe we should stimulate overconfidence.
Thanks for your comment. I guess the way to look at that would be to use a longer panel, and we still need to figure out what the individual long-term effects are, as in when you're sick or when you over underestimate, what does that mean about your health in a few years ahead. That's something we can't look into with SHARE, because SHARE doesn't do those biomarkers every year. But that's certainly something we could do with different data sets that have it more regularly. And then it would be super interesting to see if those people in the long run also save the system money.
Any more questions? Okay, I'm going to use chair prerogative again. Guillaume. So I was confused about how the ADLs were measured that went into your health metric.
Sorry, one more?
The ADLs that went into your health metric, where did that information come from?
You mean the fact that I put 60 as a...
No, you put a variety of things into your health metric, didn't you?
Well, the health metric I didn't build it myself. This is something from like another project of the Aptos thing.
Okay.
So it's like they have a list of items, 80 items, and then they try to build as kind of standardized health metrics that will be comparable in the world, in the different countries, different contexts. And so I didn't choose anything. This was like a part of the survey already. It was provided by the project.
Right, okay.
Yeah.
Well, I'll maybe ask you that question later and not put you on the spot. Any further questions? Okay, well, see you at dinner.